So thank you for having me to speak about intentional antiretroviral non-adherence and how can we as providers respond. And by providers, I mean all those who work in the HIV field. So thank you for having me. I've previously received honorariums from Gilead and ViiV. So this is quite an emotive subject. I've worked in HIV for 25 years now. Many of those years were in palliative care, and I also worked as a Macmillan nurse with end-of-life patients, predominantly who were dying from cancer. And I've looked after many people who are palliative that would have given anything to have life-sustaining treatment, to have been given that opportunity to survive. And in the past few years, looking after people who have actually chosen with capacity to stop their medication has been really, really challenging for not just me as a specialist nurse, but also for consultants, registrars, and other healthcare professionals looking after those patients. So ultimately, as healthcare providers, our aim is to promote a healthy lifestyle and to deliver high quality care to enable people to live long and healthy lives. That's what we want. We want to see people reach their potential. And adherence is an important outcome measure because non-adherence to ART increases morbidity and mortality and health service costs, as well as the risk of resistance and onward transmission. And this presentation will explore how we approach and manage those patients who actively choose to opt out of treatment. And this is otherwise known as intentional non-adherence. So non-adherence falls into two categories, intentional and unintentional. And unintentional non-adherence we see very often in HIV patients, and it's when a patient unintentionally struggles to take their tablets due to barriers that are beyond their control. For example, forgetfulness or drug and alcohol issues or complex mental health issues. And intentional non-adherence is when a patient intentionally decides to stop their treatment. So very, very different. In order to better understand adherence to treatment, we need to consider the factors that influence the patient's choice to stop treatment. And applying this approach in practice requires a holistic, empathetic, and no-blame approach. And I can't emphasize enough the no-blame approach, encouraging discussion around intentional non-adherence and any doubts or concerns patients have about their treatment. So globally, we're doing really, really well. We've got 81% of people aware of their HIV status, 82% of those are on HIV treatment, and 88% of those on treatment are virally suppressed. And in the United Kingdom, the UK has made significant progress in antiretroviral treatment coverage in the recent decades. And I've seen that, having worked for the last 25 years in HIV, it's been amazing to see the progress we've made. And overall, 87% of people living with HIV in the UK are virally suppressed. But there is a significant amount of people that aren't virally suppressed. And why is that? So a caseload review identified reasons why patients opt out of ART or struggle with adherence, and barriers to adherence were identified. Just to point out, the methodology was carried out in my previous post, in my previous trust, and case studies also taken from the caseload from my previous trust, not from the trust I work in now. A comprehensive caseload review was undertaken to identify and explore why some HIV positive patients decide to stop ART. And we reflected on past cases to identify key components of a best practice model. 14% of the caseload of patients had a detectable viral load. And of those with a detectable viral load, surprisingly, 40% had opted out of treatment. They had chosen actively to stop their treatment. So barriers to intentional non-adherence were associating tablets with HIV-related stigma, daily reminder taking that tablet, and I'd rather not be reminded every day that I have HIV. adoption of personal belief systems such as religion, alternative therapy, traditional medicine, and also conspiracy theorists. And we did see a few of those. But religion was quite significant in this caseload of patients. Slow progress as you felt well, so why do I need to take my tablets? Lack of trust in healthcare professionals. And I think that, you know, we had patients who had terrible drug interactions, which had resulted in hip replacements and you know, sustained issues. And you could understand then why there was this lack of trust in sort of consultants and specialist nurses. Denial, fear of side effects, medication fatigue. For our patients that have been on HIV medication for a long time, this is understandable. Invincibility and optimistic bias, depression, low self-esteem, and social isolation we saw a lot as well, where there's no incentive for good health and well-being. And when you live alone and when you don't feel like anyone cares about you, why would you bother looking after yourself? You've got no one to look after yourself for. So again, this was understandable. We understood where people were coming from. Cyclical periods of good, poor health coinciding with stopping and starting ART, a desire to survive but not with HIV, the need to exercise control. Again, this was significant in what we saw, and a punishment to significant others. We also saw this. And then simply a desire to die. Sometimes people were just tired and no longer wanted to live. So control issues are really, really quite interesting. We cannot underestimate the need for control. And for some people, choosing not to take life-sustaining treatment is about regaining some control, similar to the complex nature of eating disorders such as anorexia and bulimia. And Brown in 1990 discussed that control paradox. The power struggles in therapeutic relationships are disastrous as they force people who feel out of control to cling more desperately to the only control they have. And we see that power dynamic quite often between health professionals and patients. So in other words, the more practitioners try to take power away or enforce their opinions on someone, the more the patient's symptoms and behaviours are likely to escalate. And what's our response? The right to die is a highly emotive topic, as I've already said, and respecting someone's choice to die is incredibly complex. And liberty and autonomy or self-government are sources of human dignity too. And the GMC discuss personal beliefs and medical practice, and they state you must respect a competent patient's decision to refuse an investigation or treatment, even if you think their decision is wrong or irrational. You may advise the patient of your clinical opinion, but you must not put pressure on them to accept your advice. And being completely honest, I have often put pressure on my patients because I feel I know best and I want them to be okay. Mental capacity is really important, assessing a patient's mental capacity in these situations when someone is refusing treatment. Capacity means the ability to use and understand information to make a decision and communicate any decision made. And a person lacks capacity if their mind is impaired or disturbed in some way. And this means the person is unable to make a decision at that time. And the language we use is also really important. So compliance, which often is used in healthcare settings, relates to a more paternalistic or even autocratic relationship in which someone is seen as either following instructions or disregarding them. And when we label a patient non-compliant, this emphasizes, by health professionals, it becomes a barrier to empathizing with the patient's perspective. It prevents us understanding why the patient is unable or unwilling to adhere to lifestyle changes, medication regimens, or our advice. It places responsibility for a perceived failure to optimize health outcomes on the patient, and it assumes that healthcare professionals know best. Concordance is a much more positive word, and it's an indicator of the quality of decision-making in healthcare. It depends on patients being well informed, so a concordant relationship promotes self-management of health. It's based on trust, enabling patients to discuss with the health professionals providing care how other aspects of their life influence and are influenced by health and health interventions. It is a partnership to achieve the best health and well-being outcomes. So what is the role of the practitioner? And Michelle Croston, who's going to be speaking after me, is going to speak in detail about this. So it flows beautifully. So what is our role? Our role is to help patients to develop strategies to incorporate lifestyle changes or medication into their routines, to support significant others, so mums, dads, siblings, partners, daughters, sons, supporting and managing change of mind. And this is difficult without putting pressure on the patient. Shifting emphasis from medication to other pressing issues. Robust MDT working and communication. And when I talk about robust MDT working, I'm not just talking about MDTs between HIV consultants and HIV specialist nurses. I'm talking about robust MDT working between GPs, practice nurses, district nurses, palliative care teams. That is what I'm emphasizing. Advanced communication skills, listening skills. Resilience and patience. Resilience is a word that people are debating at the moment, but not showing frustration to our patients and having realistic expectations. Maintaining engagement. And one thing I've noticed over the years is that quite often when a patient decides to no longer take their treatment, they're forgotten. And actually, these are the patients that we need to engage with more than anyone else. So even if they're not taking their medication, maintaining engagement, keeping in touch with those patients, a flexible approach to tailored care, advocacy, timely referrals to palliative care, so 1 year before anticipated death, and prepare to adjust our communication styles to meet our patients' needs, ask about prior experiences of medication, and it's amazing when we do that, what we identify. Respond openly and honestly to questions about medication and side effects. Be honest with our patients, and they really respect transparency. Provide motivational support, but don't be disappointed with non-adherence. Try to understand it and respect our patient's decision. And I'm just going to end with a couple of case studies. And these are patients that I've personally been involved in. So we had a patient, it's all anonymized, by the way, not their real name. So we had a patient called Ben. They were 22 years old. He had got HIV from his mum, so vertical transmission. He was told he was HIV positive mid-teens, and he was told that was why he'd been taking medication since birth. And he really struggled with acceptance and adherence since then. There was a very significant power struggle between Ben and his mum. And from my observations, it almost looked like he was trying to punish his mum by not taking his medication. And he did stop taking his medication. We had multiple MDT discussions about this young man, and we tried different interventions with Ben. Mental capacity was discussed multiple times, and he had capacity. Specialist doctors and nurses found it hard to accept his decision. It was just absolutely devastating to watch this young man with so much potential slowly deteriorate in health. And he died at 22 years of age from end-stage HIV on a hospital ward, which is something we shouldn't see anymore. And on reflection, what could we have done better? And I remember thinking about my involvement with Ben and thinking, you know, so much of my discussions were trying to convince him to take his medication. And I wish I'd spent more time just understanding him and understanding his fears and understanding where he was coming from and accepting his decision. So then a little later after Ben died, we had a patient called Peter, who was 30 years old. And actually, as a team, we our way of sort of caring for Peter was so different to Ben. Peter decided he would rather die. He couldn't accept his diagnosis, and he stopped taking his ART. We respected and we accepted his decision, literally said, that's fine. If that's what you want to do, that's fine, but we're here for you. We referred him to the palliative care team, a DNR was put in place, and we did advanced care planning with him. We visited Peter for over 2 years, often just to listen and maintain engagement with him, always hoping he'd change his mind, but at times feeling quite hopeless that that would ever happen. In November 2018, he suddenly changed his mind and decided he didn't want to die. And he started taking his antiretroviral therapy. His present day viral load is below 30 and his CD4 count is high above 200 now. And he is happy and he's come to accept his diagnosis. It's an amazing outcome, an outcome that we wanted to see. And then the third case study is Paula, who's 38 years old. She was a hoarder, intermittent engagement for 5 years, very religious lady, had a strong belief that God had healed her. In fact, her pastor had also told her that by taking the HIV medication was showing a lack of faith. So she stopped her ART. She was finally admitted to hospital with a CD4 count of 11, and she was discharged from the ward 3 days later. Clinically, she was dying. We admitted her to the hospice early 2018 for end-of-life care, and she looked skeletal. She looked very near to the end. She started taking ART whilst in hospice as she suddenly became frightened of her imminent death. She's now undetectable with a CD4 count of much over 200, doing really, really well. So conclusion, trust is the most important factor in patient satisfaction and adherence to care. Health professionals, as healthcare professionals, we need to develop that concordant relationship with our patients. And it's vital for us to understand the psychological reasons and issues which lead to someone choosing to opt out of ART. So we are better able to help our patients on their journey. And our duty of care remains the same with patients who choose to stop ART as those patients who carry on taking their HIV medication. Our care should always remain high quality no matter what our patients choose. Anyway, thank you very much for listening to me.